Okay, I think we're at critical mass, so we will get started. Welcome everybody. Good afternoon, good morning, wherever you may be, to Manatt Health and the eHealth Initiative's webinar on contact tracing. We have titled it, Where Are We Now? Where Are We Going? What Have We Learned? We're going to be covering quite a lot of ground in a relatively short amount of time. We will leave time at the end for questions and answers, and I'm so grateful to all of you who've joined us. Next slide, please. This is a brief agenda. I will introduce my colleagues and co-presenters, and then we will do an overview of what contact tracing is. That term is thrown around so much now that we thought it would be helpful to do as deep dive as possible in this allotted time period of what that actually means and what contact tracing efforts look like both for COVID and other diseases. Then we'll do an overview of digital contact tracing tools, including the contact tracing apps we all are reading and hearing so much about. We'll do an overview of where the US stands with respect to digital contact tracing implementation, the international efforts we've seen to date, and the challenges that those have presented and lessons learned as we move forward. And then a number of you asked even before joining today about the privacy implications of these technologies. And so we'll talk about that and some potential legislative fixes at the end. And then, as I said, open it up for questions and answers. Next slide. And the next slide after that, I'll do an introduction of myself. I'm Alice Leiter. I'm a Vice President and Senior Counsel at the eHealth Initiative. I am a health privacy regulatory lawyer by training. My specialty is in HIPAA and HIPAA privacy issues. And I'm joined by two colleagues from Manatt Health, Dr. Ben Chu and Bob Rebitzer. Dr. Chu is a senior advisor for Manatt Health Strategies. He's a physician by training and has spent the better part of the last 20 years running health systems as CEO for the New York City Public Hospital System. He's also president for the Southern California region of Kaiser Permanente and CEO of Memorial Hermann Health System in Houston. He also briefly served as the New York City's acting commissioner of health in the mid-1990s, so brings a public health background to his work as well. And Bob Rebitzer is the managing director of Manatt Health. A managing director works with leaders of healthcare organizations on strategies to reduce costs and improve quality of care. He was a partner and founding member of Accenture's strategy practice in the healthcare industry and has been a senior vice president in United Behavioral Health and was the founding chief operating officer for Stanford University's Clinical Excellence Research Center. So other than me, really an all-star team here to support you or to teach you all about this. Next slide, please. Just a couple of housekeeping things. We've muted all of you. We are all so adept at Zoom now that we know how insanity provoking it is to hear the background noise. So please do try to keep yourself on mute. And then as questions come up throughout the presentation, please use the Q&A box at the bottom of the screen to ask those questions. And we'll reserve the chat box for any technical difficulties or questions or comments that are unrelated to the content of the presentation. We will also make the slides available after the presentation on the eHi website. You see at the bottom the site for that. Next slide. Given our limited time, I'm not going to do a deep dive into who eHi is, but it's a membership organization where we convene executives involved in transforming the healthcare industry through technology and innovation. Next slide. You'll see here some of the companies involved in our leadership. Next slide. And our primary issues, substantive issue areas of interoperability, transparency, analytics, and privacy. Next slide. And then Manatt Health is a division of Manatt, Phelps & Phillips, a law firm, and it's an integrated legal and consulting practice throughout the country that supports states, providers, and insurers with the understanding of our very complex and evolving healthcare policy and regulatory landscape. And you'll see at the bottom the Manatt website as well. All right, next slide. I'm going to turn it now over to Dr. Chu, who's going to tell us about contact tracing.
Thank you, Alice. The overall playbook for COVID-19 pandemic control is really a relatively straightforward initiative. It involves bringing cases down to manageable levels through various strategies emphasizing social distancing, adoption of hygienic practices, mask use to decrease transmission of the virus, and building capacity for testing to be able to identify new cases quickly and accurately, and aggressively isolating cases and quarantining at-risk individuals through robust and timely contact tracing to reduce the likelihood to infect others and to contain the virus. Numbers of countries have had success in containing the virus with this approach. Absent any effective treatment or vaccine, effective deployment of this playbook is really critical to return to a more functional society. This webinar will look at contact tracing and efforts to expand its reach and effectiveness, largely through digital technology. So what is contact tracing? The next slide, please. Contact tracing is a tried and true public health strategy to respond to and contain infectious disease outbreaks such as tuberculosis, sexually transmitted diseases, SARS, and Ebola. The aim of the contact tracing process is to break the chain of transmission for the infection by judiciously identifying cases, reaching and interviewing each case to provide guidance for appropriate intervention and support services through the course of the infection, and eliciting information on individuals who may have had close contact or are at risk of developing the disease. At-risk contacts are then reached to provide education and guidance on the illness, on appropriate intervention and support, and on follow-up for the development of symptoms and illness. With COVID-19, the main public health intervention right at this point is effective isolation of cases for the infectious duration of the illness and quarantining close contacts, monitoring for developing COVID symptoms in order to prevent further spread. Next slide, please. While contact tracing is a relatively straightforward concept, the process is time and resource intensive and requires a skilled workforce and coordinated systems to carry out. Adequate and timely testing, as I said before, is a prerequisite for effective program. The average time to infection is about 4 days from an active case to the next. So delays in getting and reporting test results, in eliciting comprehensive lists of contacts, in reaching cases and contacts, and in achieving effective isolation and quarantine reduce the effectiveness of the program. Confirmed cases come through providers, laboratories, public health outbreak investigations. They're interviewed, usually by phone, to elicit complete and accurate information about close contacts that they may have, that may have been exposed during the time when they were infectious. They're provided education and isolation guidance, and as needed, referred for community service to really support them during the isolation period. And these services may include places to isolate, meal and family support. Follow-up and monitoring is attempted during this period by phone or other digital platforms such as email and text. And then contacts are reached and provided education and guidance regarding symptoms, quarantine, testing, and support for quarantine periods. And follow-up monitoring and support can also be provided through phone or other communication vehicles. Next slide, please. It's critical with COVID-19 to ensure contact tracing is conducted quickly and thoroughly to limit the spread of infection and interrupt the chain of transmission. The virus is transmitted through aerosolized droplets. It's now understood that there is significant transmission through asymptomatic and pre-symptomatic individuals. This presents a huge challenge for disease control. And as we have experienced, high degrees of transmission leads to rapid community spread that reduce the effectiveness of any test, trace, and isolate containment strategy. The current lack of effective treatment makes it even more essential to get to potentially infectious cases and contacts as quickly and as efficiently as possible, to isolate the cases and to quarantine the close contacts. Every delay reduces the effectiveness of the program. Next slide, please. Standing up a robust contact tracing system in the middle of a pandemic is a daunting operational and financial task. Transmission models suggest the need to be highly effective, required as many as 70% of contacts to be traced to contain an epidemic. Key issues involve recruiting, training, and scaling up an effective workforce, developing and implementing technology to support efficient operations and facilitate the process at the scale required. Building individual and community trust that improves cooperation in disease control measures, eliciting comprehensive lists of contacts, and achieving timely adherence to isolation and quarantine requirements for most cases and high-risk contacts, and finding adequate funding for the operations. Next slide, please. Contact tracers need to be skilled workers, familiar with medical context and terminology. They need good interpersonal skills to build trust and provide crisis counseling. And they have to demonstrate high degrees of cultural competency to work with diverse populations. There have been calls for the need for at least 100,000 contact tracers, or about 30 per 100,000 in the United States. Others have called for up to 300,000. This will be, I think, a dynamic number based on the case rate, the transmission patterns, and local factors. Wuhan, China, for example, had 9,000 contact tracers for a population of 11 million, or 81 per 100,000. Nationally, we are nowhere near the 30,000 that's been called for. The 30 per 100,000 have been called for. Phone-based contact tracing staff are being recruited to supplement and support more traditional outbreak investigation and contact tracing teams. There is also a considerable need to increase the number of these public health teams. Work largely through phone-based tracing is time-consuming and imprecise. Early reporting experiences outline problems with response rates, low numbers of contacts elicited per case, and metrics for effectiveness, such as timeliness from specimen collection, effective isolation and quarantine, etc., are not generally available. Also, of course, rising caseloads can easily overwhelm tracing programs, particularly with timeliness from testing to isolation and quarantine. Next slide, please. So while phone-based outreach have had significant difficulty with adequate response rates and contacts provided, thus far, response rates, completed interviews, and numbers of contacts elicited have been relatively low. There's little, and as I said, there's little data on successful isolation and quarantine. Efficient workflows are hampered by integration of disparate data streams, electronic transfer of information from new testing labs and providers that are not uniform, and electronic, requiring manual data entry. Incomplete contact information hamper efficient time-sensitive operations. Case management and care coordination are important issues to address with various with systems design. There's a need and interest in developing technology tools that could automate and optimize outbreak investigations, contact tracing processes, case and contact follow-up, and monitoring that could provide analytic capabilities to better track and target outbreak investigations. Tools to facilitate interviews, such as digital surveys, exposure notification, which we'll talk about in this presentation, symptom tracking and follow-up, and care and team coordination may offer promise in streamlining and expanding contact tracing capabilities for this highly time-sensitive public health imperative and free up resources for more productive outbreak investigations. Contact tracing apps and technology aids, particularly for contact elicitation and exposure notification, have potential but are largely unproven. To be effective, they require significant participation and uptake by the population served. Next slide, please. Successful contact tracing programs really rely on the population's willingness to act in the best interests of the community. Trust that the information will be used for everyone's benefit is a key factor. Communities of color, immigrant populations disproportionately affected by COVID may be wary of responding and offering contacts. Also, politicalization of public health measures is a barrier to adherence to sensible practices such as social distancing, use of masks, and cooperation with contact tracing outreach efforts. So to be successful, contact tracing programs must convince cases and contacts to isolate and quarantine for up to 14 days a major disruption for a person's life. Further use and development of contact tracing apps are hindered by privacy concerns in the United States and in Western countries. Next slide. And finally, current models for contact tracing call for billions of dollars in investment in tracers. The Association for State and Territorial Health Organizations estimated the need for about $3.6 billion per year. Others have included costs to provide support for those cases and contacts asked to isolate and quarantine, including income support. And those, of course, are much larger figures. To date, only about $600 million have been explicitly provided to the CDC for contact tracing. The CARES Act funding for testing, $25 billion worth, could be used to offset some of the costs for contact tracing. In the current negotiations, two proposals are currently being proposed to add additional increments to these funding sources. And with that, I'm going to turn this back over to you, Alice.
Thank you so much. That was a lot of incredibly valuable information. I encourage, again, all of you who have questions, either for Dr. Chu or Mr. Rebitzer, who will help with the Q&A at the end, to submit your questions in the Q&A box at the bottom of the screen. I'm now going to talk about some of the digital contact tracing tools that were referenced, and as I said, then go over some state-level examples of how they're being deployed in the US, some international case studies, and some privacy implications. I meant to add at the beginning that this topic is so broad and so complex, and we're trying to cover so much, that I just issue the blanket caveat, at least for me, that I am not an public health expert, nor a technologist, nor international legal expert. So as I go through what is admittedly just a surface level overview of all of the material that I'm going to cover, if there are questions that come up that I cannot answer, I promise to get back to you at a later date. So with that, CYA in place. Next slide, please. When we talk about contact tracing and we think about technology, everybody tends to think just purely of an app, which might make it seem like there is a one-size-fits-all app that does contact tracing. And that's really not the case. There are a number of different contact tracing tools that rely on electronic data and digital technology. And they generally fall into three main categories: outbreak response tools, proximity tracing tools, and symptom tracking tools. Outbreak response tools are really designed for public health purposes to assist the public health on the ground workers who are involved in contact tracing activities and outbreak investigations. And they enable these really large scale data collection and analytic capacities and capabilities to streamline all of the contact tracing efforts that Ben just outlined. And you see at the bottom some examples of these tools that are used today and are in place. The proximity tracing apps are the ones that have gotten more attention on the COVID front, because they're really designed to detect and trace. They use, in some cases, GPS technology to track locations of individuals and to identify those that may have been exposed to somebody who is infected. They also often use Bluetooth technology to engage in what is referred to as a digital handshake. This is when two mobile phones that are near each other detect each other over a Bluetooth network and sort of send chirps, is the technical term that's used, to notify an individual who's come into contact with somebody who's been exposed. This data is then fed into public health databases, but it depends whether or not that data is automatically transmitted to a public health centralized database, or whether it ends up residing on the user's mobile device, known as a decentralized system. It can be used by both public health authorities and individuals. And then there are the symptom tracking apps, and these, as you can get from the title, are really reliant on self-reporting of signs and symptoms of the disease. And a number of other countries have used them to help enforce compliance with quarantine orders. It really, these apps tend to help provide a map of disease severity and probability of spread and infection. Next slide, please. As with all technology, there are great benefits. They can be enormously effective in implementing a much larger scale contact tracing effort than would be possible merely with our devoted frontline humans on the ground. They also have the ability to improve data collection and quality. There's a heightened probability of accuracy in the scale of the data. The breadth of the data that can be collected is improved when you're using digital technology. Obviously, the amount of data that can be collected, but then also the time in which it can be collected is both expanded with respect to capacity, but shortened with respect to collection time. And then once the data is electronic, the ability to analyze it and to use it for public health efforts is dramatically improved when it's been collected digitally. And finally, as we'll talk about later, perhaps the greatest benefit of digital contact tracing tools isn't for use themselves or any one thing that they're doing, but it's to provide this large scale ability to support traditional contact tracing efforts and to streamline the work that those teams are doing. Next slide. When COVID hit the States, there was a lot of attention to some of the early announcements of digital contact tracing efforts. These are not the only two, MIT's SafePaths and Apple and Google's exposure notification technology, but I'm just going to highlight them because I think they were probably the highest profile and among the earliest to be announced and discussed. The MIT tool was developed or is in the process of being developed collaboratively, not only with MIT, but with the Department of Health and Human Services, Harvard University, and the Mayo Clinic. It is an open source tool that public health agencies and individuals can use both to track and trace positive cases of COVID. And it depends upon both GPS and Bluetooth technology to log locations and send these chirps and pings to other users once people have tested positive, uploaded that information, and provided health officials with a record of their locations. This, I believe, is still in beta testing, but a number of countries and some cities and states have expressed interest in using it once it's fully operational. Most of the press attention given to contact tracing technology in the US has been focused on the Apple-Google partnership to develop an exposure notification API. An API stands for Application Program Interface. It was launched in May, and rather than being an app itself, it's the technology that enables these apps to do their contact tracing job. They're interoperable. They work on both Android and the Apple iOS systems. They are enabled by Bluetooth. They're voluntary, meaning you opt into having this technology on your device, and the platform is decentralized, meaning that the data is not fed into a centralized singular database. It relies on your phone and the data stays with you. Only at this point, a small handful of states have announced their willingness or plans to use the Google Apple API. You see these three, Alabama, North Carolina, and South Carolina listed here. There are a number of countries that already have put the Google Apple technology into place, and a number of others that are planning to do so. And we'll talk a little bit about that later. Next slide. Without going into a long discussion of the American response to COVID, its coordinated response or lack thereof, as with so many things involving data, privacy, and healthcare in America, there has been a really state-specific response to this pandemic and to the willingness or ability to deploy technology to combat it. A number of states have said they're going to develop their own contact tracing app. As of today, only 3 states have actually launched them. That's North Dakota, South Dakota, and Utah. But as of about a month ago, there were a couple dozen states that said they're either in the process of developing their own contact tracing app that will or will not use the Google API technology. Some states have not yet announced their plans to do anything involving digital technology one way or another. And then there are some states who've come out explicitly and said, no, they don't plan to use any smartphone-based contact tracing. And in a few slides, we'll talk about the reasons why states and or individuals might be skeptical when it comes to using this kind of technology. Just a little bit about the state efforts that are in place. The Dakotas have put into place an app called Care 19. Here, users download an app onto their phones. And if you test positive for COVID, you upload that information and you consent to sharing that data with the state's Department of Health, which of course supports the state's contact tracing efforts and ability to predict what's coming down the pike. But you'll see here that a very, very small percentage of residents of these states have actually downloaded and used the app. And I'll talk a little bit about, and actually Ben mentioned too, how much the success or even utility of these apps depends on user uptake. In Utah, the app is called Healthy Together. It's one of these exposure notification apps, but you'll see again, and admittedly this data is a month or 6 weeks old, but all signs point to a very, very small percentage of uptake in state residents. Next slide. By contrast to the US, the efforts internationally to combat COVID and deploy digital technology has been earlier, as that's where the virus hit sooner, and in some ways more successful than we've had to date in the US. There are a number of countries that we could talk about in both Asia and Europe, which I'll talk about on the next slide. So this is by no means an exhaustive or comprehensive overview of efforts across Asia or Europe to use this technology to combat the disease. But there's some important standouts from Singapore, from South Korea, and China of how these countries use the various types of technologies to trace and track the disease. Singapore was the first country that rolled out digital contact tracing technology. It's known as Trace Together. It's Bluetooth enabled, it's voluntary, meaning again that you have to download the app onto your phone and use it. About a third, around 35% of residents of Singapore have downloaded the app, but its actual efficacy was found to be quite low. For example, apparently on Apple phones, the app has to be running in the foreground of your phone at all times to pick up and detect the other Bluetooth signals nearby. It was an enormous battery drain and was just not seen as being particularly effective. The country more recently has added wearable devices, tokens, to fill some of the gaps that the original Trace Together technology was experiencing. And it was initially distributed to a population of people who might not either have or use their mobile phones, specifically the elderly who are less digitally connected. These tokens, they're wearable, they are not connected to the internet. They have a battery life of up to 9 months, so they have been seen as fairly low maintenance and easy. And then when a device detects, or when a user tests positive for COVID or detects that he or she has been in touch with somebody who has been who is COVID positive, a positive user will give the wearable to a public health official who then can look at the data that's been stored. I believe it's stored for 25 days at a time to be able to trace the movements of somebody wearing one of these devices. South Korea is another country, I think one of the lowest mortality rates from COVID in the world, has fared fairly well with digital contact tracing efforts. South Korea did not rely on any one specific contact tracing app, but rather using a variety of anonymized data sources to compile and detect positive cases and the locations of infected individuals. And this included GPS phone tracking devices, CCTV footage, credit card transactions, phone records, and meticulous on-the-ground manual contact tracing efforts. And the sort of combination, all of these various data sources, the combination and then the analysis proved pretty successful in getting a fix on the spread of COVID. And then there's an app known as Co100 that's been used in South Korea that's been the most popular to leverage all of these various types of data for contact tracing purposes. And then in China, another country that's received an enormous amount of attention when it comes to not only the spread of, but the combating of the virus, took another approach. It enlisted domestic technology companies to base quarantine apps, they're called, but that are based on QR codes. Those are sort of those Rorschach test looking barcodes that track individuals' COVID status. All residents of China are required to register for health codes. They have to download this technology onto their devices, report their travel history, report their symptoms. And then these apps, based on this data and a wide variety of other user data, including their location data, based on an algorithm, assigns each individual a color code that enables them or prohibits them from entering or traveling to various public places. So you have to scan your QR code before entering certain places that are more public, like a restaurant, public transportation, shops, and sometimes even work. Again, I will just say that I am not equipped to go into any deep dive about any one of these countries, but they are have been widely publicized as using fairly different contact tracing efforts than we have so far here in America. Perhaps not that would work here in America, but really interesting to look at how they handled this and the various success rates that they've had. Next slide. Europe, the overarching, Europe obviously has a number of different countries in it too, so it's hard to sum up and say how Europe has handled this, but I think the overarching word that could be used to describe the European experience to digital contact tracing technology has been fragmented. There have been interoperability challenges. There have been challenges with various countries using their own individual apps that may or may not be compatible with each other. There are a number of European countries who started out down one path with a certain type of technology and a certain type of database system and changed course because of the either rollout or public perception of plans. And so it does seem like there has been a little bit more turmoil when it's come to the European or in some of the individual European countries' rollouts to these various technologies. Again, I'll just highlight a few countries and a few of their experiences. In France, the app is called Stop COVID. It is a Bluetooth-enabled app, proximity tracing app, as we discussed. And all of the positive cases and positive contacts that are identified through this Bluetooth system are uploaded into a centralized database. That was met with a lot of criticism because centralized databases are seen as being less privacy protective than decentralized technology. France declined to use the Google Apple API technology, which is decentralized, and actually at one point asked Google and Apple to develop a workaround so that they could employ their plans using the Apple Google technology. Those two companies declined to do so. And so as a result, France has an app that they've developed on their own, but that has not been used by very many people in the country. One statistic I saw said it's been 2.3% of the population has downloaded Stop COVID. There have also been there's been a lot of attention to how relatively infrequently the app pings any notifications whatsoever. So you can imagine that if you have a Bluetooth enabled app and you're going about your life and you're not receiving any notifications at all, it sort of decreases the likelihood that an individual would continue running this app on the phone. Germany was a quick responder to COVID and announced plans early on for a number of different apps, a number of which were getting tested and getting a lot of attention. But there were also enormous and widespread privacy concerns, surveillance concerns, and a lot of pressure put on the government to change course. So relatively late in the end of April, the civil society group sort of had a victory in changing the country's approach to what technology they would use and how they would set it up. They're now using an app called Corona Warn, which relies on the underlying Google Apple exposure notification, which is seen as being relatively privacy protective and using this decentralized model that tends to make privacy advocates and civil society advocates feel a little bit better about the privacy implications. The most recent data I saw said that about 15% of the population has downloaded this, so more than France, but still significantly below where a population would need to be in order to have these apps be seen as particularly comprehensive. And then finally, I'll just touch on the United Kingdom. Again, started a trial of a contact tracing app that it had developed using a centralized model. It decided to go it alone and not use the Google Apple API. But the preliminary rollout, which was done on the Isle of Wight, was largely seen to be a resounding non-success. There were security flaws, there were problems with usability, people didn't trust it, and it was, just seen as a non-starter. So the UK pivoted and is now using the Google API technology, relying on a decentralized model, and has had at least more sort of public perception success with its approach to using a new kind of technology in the UK. I'll also mention that about 6 weeks ago, the European Union did announce plans to standardize all of the apps among member countries in the EU. So hopefully the fragmentation and the interoperability challenges that have been in place in the early months of the virus will get ironed out, and there'll be a more comprehensive and standardized approach across Europe. There are also, obviously many more countries in the European Union than I've touched on here, but there are a number of other countries, similarly to the various states that have announced plans, who have said they are going to be using Google Apple API technology, either because they're in development or they have their own apps that they're testing right now, and those include Italy, Ireland, Austria, and Switzerland. Okay, next slide. Challenges, lessons learned. Let's dive in. Next slide. So just as it's easy to sum up the benefits or the potential benefits of contact tracing technologies, it's also quite easy and readily apparent by the 6 countries that I just ran through to see what the challenges that are inherent in these tools are. And this may sound like a statement of the obvious, but to really effectively contact trace, even if you're talking about manual contact tracing efforts, but particularly when you're talking about technology that's deployed on individuals' mobile devices or personal devices, it's by definition invasive. It's on your person, in your most valuable tool. It's tracking where you go and who you come into contact with. And so there are some people that just get an ick, very technical term, to the idea of being traced by your technology and having your health status identified and communicated by your own individual device. And I mentioned earlier that there are a significant number of US states who've just said this is not the direction that they're going to go. And one can imagine that if you dig down into why, one of the sort of threshold issues is that some people just find this an unappealing way of managing disease. As we mentioned, or as I mentioned in a number of the countries that I talked about in the Asia slide, tracking the free movements of citizens, blocking free entry and movement of citizens, that's just not something we do here in America. And surveillance worries are always prevalent and always come into play when we talk about technology. But given the increased focus and lens and prioritization on COVID tracking, there are a number of reports by civil society groups and consumer advocates who've come out and said, if you're going to do this, you have to do it in a way that's consistent with our principles and our freedoms and our privacy. And unfortunately, some of the more effective contact tracing technologies really do involve surveillance and QR code based access, and that just doesn't seem like something that's going to be particularly successful in this country. And then a number of the contact tracing models involve a centralized database. So, you have your information and your data that you have personally either in your brain or on your phone. But in order to be the most effective at getting a full map of the disease and how to track and trace, you upload it to some sort of public health or state-run or country-run centralized database. And those might have the benefits of doing the best job at getting a handle on where the disease is and how it's spreading, but they are more vulnerable to privacy and security risks. And even aside from COVID, anytime we talk about public health efforts or even not public health, but just health system efforts that involve centralized databases, there are always privacy and security concerns. They're just more vulnerable to breaches. It's more challenging to control use and access. And so it's yet another example on this topic of how it's a balancing act between what's the most effective and what's the most consistent with our values, including privacy and our risk tolerance. Next slide. Again, it's very difficult to sum up all of the lessons learned from international experiences, just as it is very hard to sum up what have the international experiences been. There have probably been as many international experiences as there are other countries. But we are fortunate to be able to have learned from some of the countries that were ahead of us on both virus outbreak and transmission, but also effective combating of it. And I think probably the biggest takeaway from all of the various international experiences is that digital contact tracing tools can help. They can be an important part. They can be a valuable addition, but they are not a magic bullet. As I think I said earlier, one app is on one person's phone is not going to fix this. It is likely to be, when we look back on how the COVID tail unfolded, we will likely see contact tracing efforts as being a full spectrum of complementary efforts, some of which involve digital tools, but certainly not that there was one be-all and end-all technology that was the answer to getting a handle on COVID. And then more broadly, as I talked about this balancing act, when we talk about our priorities, if you're talking about identifying and curbing and stomping at the disease, and that's the be-all and end-all priority, you would take different actions than if your priority was to protect individual privacy and individual liberties and freedom of motion. It's really challenging to say both of those are our head and shoulders priority. You really do need to make some trade-offs. And some countries seem to have prioritized privacy more so than curbing the disease, and others the disease spread more than privacy. And there's no right answer, because the countries that have had maybe more success in stamping out the spread have been seen as violating civil liberties. And maybe in countries where there's been a little bit more emphasis on privacy, the transmission rate has been greater, and public health implications of protecting privacy more than others. And then a really important part of all of this that I just don't think we can overstate is that any app, whether it be any one of the categories of contact tracing apps, anytime we're relying on something that an individual user needs to put on his or her phone and then use, it really relies maybe not on 100% adoption, but something that's pretty close. The most commonly thrown around statistic is that there's a 60% threshold for effective use of contact tracing apps, so that the Bluetooth communication really provides an accurate picture, but others say it's much closer to 80 or 90%. And so if it's not mandated that every single person with a mobile phone downloads this app and that there's some sort of way to enforce that, it's probably not going to ever be that any one contact tracing app is particularly effective. And you saw again that here in the states where there are those few states that are using apps, we're in the single digit, even significantly below 10% adoption rate, and that's just not going to cut it. So we really need to think about whether or not we want to prioritize the use of apps, and if so, how we're going to increase public buy-in. Next slide. And then the privacy implications of these have been mentioned in various contexts over the course of the past 45 minutes or so. But it bears a special section because health privacy and electronic health data privacy are always hot topics. They're always sensitive issues, given that there's there's nothing more personal than one's privacy, and health data has a special significance when it comes to privacy. But it really has been, I think, particularly in the United States, a barrier to fast and widespread implementation and adoption of digital technologies. So it bears a special section on the privacy implications that at least are most relevant here in America. So next slide. Again, this gets into a little bit of, dorky health data privacy people, but anytime you talk about health data, the privacy challenges involving identification of data or anonymization of data are always quite relevant. And when we talk about contact tracing, very often whoever the technology company or whoever the public health authority is that's promoting this very privacy protective health app will say the data is anonymous, but they're very often places where it's hard for anyone to truly be anonymous. And so there are all sorts of concerns that particularly in rural or low population density areas, You might not think that a particular Bluetooth signal that identifies somebody as being positive for COVID-19 would actually identify them, but when you combine it with all of the other types of electronic data that are out there, it's hard to ever say that it could be truly anonymized, and that's something that gives a lot of people great concern. And then even if we're not in a low population density area, anytime you're tracking somebody's motions, even if it's not put with a name in the face, the insight into somebody's daily activities that GPS or Bluetooth tracing data can reveal, whether or not that's actually going to be revealed, it gives people great pause. It might not be that going to the grocery store is something that you feel sensitive about, but there are all sorts of places that people go throughout their days that they may not want others to know. And so anytime we're talking about location tracking, it makes people feel very uncomfortable. And one of the very real implications of tracking activities is that it can exacerbate disparities. And anytime also there's something that depends upon technology use, it can cause downstream discrimination or disparity exacerbation when it comes to who has access to the technology, who has access to testing, who has access to healthcare. And so we always have to be very sensitive to that and recognize that that might have significant implications for public trust and buy-in. The participation has been mentioned. It's key that if we're going to have successful contact tracing app success, there has to be high participation, but we are also not in the business of mandating app downloading and use on our phones. And so given that it is entirely opt-in and entirely voluntary, we don't want people to feel they have no recourse no option other than to deploy these in some ways invasive technologies onto their phone. That tension between trying to get as ubiquitous adoption and buy-in as possible while also making it clear that people have the right to refuse, that's just tough to deal with. There are also a number of instances where there's a false positive or a false negative when you get pinged by your various proximity apps, and that can have downstream implications if we end up making decisions as a state or as a country based on somebody's proximity tracing log or location log, but that data is not accurate. That's a real concern. And then finally, another very common topic when it comes to any type of health data privacy issue is that the duration of the data storage is not necessarily clear. I mentioned in one country, I think it was Singapore, they've been very clear that the wearable tokens only store data for 25 days. It might not be as clear in some of our domestic contact tracing efforts, how long the data is going to be stored. And as a result, when COVID is over, how do you know that your COVID results are not living out there somewhere where they could have downstream implications? And again, these are sort of bigger policy issues, these final few bullets, but anytime there's a centralized database or even any kind of electronic database of health data, we are concerned about who has access to it and whether or not it's going to be used down the road for a purpose beyond a primary purpose. So perhaps somebody feels very comfortable uploading their current COVID status and you want to help a current public health effort, but you also want to be sure that somebody else or some other company affiliated with the app company doesn't have access to it, or that your data isn't going to be sold or used for some other non-COVID related purpose at some other time. Data breaches are real, they happen. The more centralized the model is for data collection, the more potential there is for one singular breach to have devastating consequences, but the actual security protocols are very important. And then, as I mentioned a little bit with the third-party access and secondary use, there has just been a lot of scholarly writing in the past several months about the potential for overreach, whereas it might be prudent to be collecting location information and disease status right now on a fairly wide scale. But once we have that data, there is great concern that at a certain point we turn into some sort of health surveillance state that we certainly wouldn't want. So those protections and those policies need to be put into place on the front end rather than trying to figure it out once the COVID crisis has passed. Next slide. Even before contact tracing, even before COVID erupted, hit us, The topic of health privacy legislation was a big one on Capitol Hill and on the state level. HIPAA is the federal privacy law governing the use and disclosure of health information. And it has been in place since 1996. It is very good at what it does, but HIPAA only applies to HIPAA-covered entities, which include providers, your doctor or your hospital, or health insurers, payers, your health insurance company. And so data that is stored on your phone or symptom tracking apps that you have, that you upload, individuals are not covered by HIPAA, so that data is not covered by HIPAA that you have personally. And most tech companies, most app companies, most phone companies are not protected by HIPAA. So again, even before COVID, this concept of health data that falls outside the scope of HIPAA protections was one that was getting a lot of attention, and there were a number of bills in 2019 that were proposed to try to fill these gaps, make the US federal protections for health data far more comprehensive, perhaps something like the European Union's GDPR. But those efforts all stalled and then sort of got reignited and reawakened when the urgency of COVID struck. So since so much of this contact tracing data that's being collected and that's dependent upon individual users, since so much of it falls outside HIPAA, it's even more important that we address the trust issues, the privacy issues, and get ahead of the contact tracing apps if and when they gain traction. And the good news is that Congress is on it. In May, there were 2 different bills proposed that were, that were motivated by and clearly very aware of the need to build public trust. The backlash to even the idea of contact tracing was so intense that I think that they're trying to get ahead of this and make sure that individuals felt that their personal data is going to be protected and that companies were held accountable for use and misuse. And in the interest of time, I won't go into the details of the bills. That they are slightly different. The Democratic bill was a little bit more popular with privacy advocates and consumer advocates and civil liberties groups because the protections of the Democratic bill were a little bit more comprehensive with fewer exceptions. But the real takeaway here is that how this legislation evolves and how it evolves in real time with the contact tracing efforts that are being launched and rolled out in various states, it really has significant implications for more comprehensive federal privacy legislation that has been in the works for a long time. And probably nothing that's going to happen, certainly not before the election, for some time, but this is a very interesting area in which we should keep focused because it's going to do a lot towards shoring up a public perception of these contact tracing tools. And so specifically for COVID, the success rate of all of the various contact tracing efforts, and specifically those digital ones, could be significantly affected by the congressional action. And with that, we're right about with 5 or 6 minutes to go. I want to open it up for Q&A. I see we've got a number of questions that have been asked in the question box, and I'm going to ask Ben and Bob to join me in answering some of these. I will just go through. We won't have time to do all, but I'll try to highlight some of the more widely relevant ones. I think we covered a lot of these. So I'm hopeful that most of you feel that these got answered. A number of questions about the federal response to contact tracing, whether or not we think that a more cohesive and clear federal response would have a better success rate for combining manual contact tracing efforts with digital contact tracing tools. Ben and Bob, do you have any thoughts on that?
Shall I start off, Ben, and then you could respond?
Sure.
Contact tracing is generally, as a function, it's generally a function conducted by local health departments. Those are usually county-based health departments. And CDC guidelines are very useful as guidance for them, but it's unlikely in the United States that contact tracing would be a federal function. So guidance from the CDC is very important, and national leadership in that way is very important. The other thing that's very, very important from the federal level is money. most jurisdictions that contact tracing is extremely expensive, and most jurisdictions have not only are their budgets affected by the economic downturn, COVID-related economic downturn, but they have no resources. The states to which they might depend for additional resources are also afflicted. So the only source of money for contact tracing has to be the federal government, and the numbers are very large. Ben?
Yeah, I think the only thing I would add to that is that because contact tracing or cooperation with contact tracing efforts are so critical, right? Not only is it important for the federal government to provide guidance and money, but really setting the tone for what good contact tracing can do would be very helpful in getting individuals in the community to really be much more open about giving contacts to someone who gets to them, so that we can actually begin to think about how we break the disease transmission chain.
Thank you both. There is an enormous amount of questions about the voluntary nature of these contact tracing apps. And I'll just state it one more time. It sort of came up throughout my presentation, but yes, one of the key challenges with the contact tracing apps is that they depend upon users downloading them, and in some cases even running them and using them. And so this concept of consent is very important. You consent to downloading the app, and then you consent to using it, and then you also have to voluntarily upload your disease status. And so if any one of those chains breaks down, there is a real issue. So yes, to all of you all who asked that, there is a real consent component to all of this. And then a number of questions about the extent to which HIPAA applies to contact tracing data. I know I sort of rushed through that at the end, but if a public health authority or a provider system, once you give it to your doctor, once that data is in the hands of an entity that's covered by HIPAA, then yes, it is covered by HIPAA. But when you get your test results and you have that information and you put that in your contact tracing app on your phone, no, that is not covered by HIPAA. And so there's a disconnect and a need to bring more organizations under the HIPAA umbrella in order to keep most contact tracing data separate. I will not go into a long tangent on business associate agreements, but to the extent that the company, your app company, has entered into a contract with a covered entity such that HIPAA protections extend, it may be HIPAA covered, but it is a real area for a need for legislative action to close that gap. And a number of you also asked about the GDPR in Europe and the extent to which that has helped European efforts. It has helped the privacy, the sort of privacy protections of the various apps, but not necessarily the standardization across the various countries and the particular technology that's been deployed. A question about Los Angeles County and just a follow-up on how the LA County has done in sort of overall in its COVID tracing and combating efforts.
Particularly around the Los Angeles County, is that the question?
Yes.
Yeah. You know, Los Angeles County is bigger than most states, and it's diverse in every imaginable way, economically, demographically, rural versus urban, and they have been hit hard by a recent rise in cases, which makes contact tracing very challenging as the volume goes up. And I think they've done a remarkable job in scaling up, and they've done a remarkable job in building on a public health infrastructure that they already had in place. That said, as the numbers get very big, it becomes a very challenging task. And so I have great respect for what they've done, but I'm sure they would feel like they wish they were dealing with a much smaller volume of cases so they could be much more effective in breaking the chain of transmission.
Well, perfect timing. It is 1:30. I'm so grateful for all of the questions, for all of the engagement. I'm so grateful to my colleagues at Manatt. Again, this is a complicated topic, and I hope we covered as much ground and with as much depth as we possibly could. And again, we will be happy to make these slides available to you on our various websites and answer any follow-up questions